कौन धर्मेंद्र? हेलो इसको पहले बोल.
So, I must congratulate organizer Dr. Alok and thanks chairpersons. They have given the opportunity to talk regularly on this HIC conclave as a faculty. This time I have been given the task of ESC guideline update on valvular heart disease. So these are the guidelines which have been updated. So we will discuss in the next few minutes regarding the updates which are there. Some new recommendations regarding valvular heart disease has came. Some revised recommendations are there. We will discuss one by one. So according to Global Burden of Disease 2020 estimates, 40 million people worldwide are living with some form of valvular heart disease, and it accounts for 1.3 million deaths annually, that is 2 to 3% of total cardiovascular deaths. And then burden is increasing due to population is aging and better survival from other cardiac conditions. So statistics shows that AS is around 2 to 4% now with more than 65 years of age. So elderly patients are predominant age group, and the common etiology is degenerative AS. AR is also up to 1%. Middle aged to elderly, they may be degenerative, may be rheumatic. Mitral stenosis is 0.1 to 0.3. Young adults, developing nation, rheumatic etiology usually. And mitral regurgitation is 2 to 3%. In elderly patients, it may be degenerative, it may be ischemic. And then tricuspid regurgitation is also 1 to 2%. It should not be underestimated. Its predominant age is elderly or in women. And secondary to LV dysfunction, there may be TR or due to pulmonary hypertension. Some new recommendations we will discuss. So, regarding the diagnosis of coronary artery disease, omission of invasive angiography should be considered in TAVI candidates. So, they say that if the CT angio is good, sufficient quality, then no need of doing the angiogram regarding decision of opening the arteries. And PCI should be considered in patient with primary indication to undergo TAVI. And if there is a more than 90% stenosis in segment with reference diameter more than 2.5 mm, there should be PCI should be done beforehand, before the TAVI. Then in severe AR, TAVI may be considered, and treatment of severe AR in symptomatic patients ineligible for surgery according to heart team. If anatomy is suitable in AR also we can do the TAVI. 2B indication is there. Indication for intervention in symptomatic and asymptomatic severe aortic stenosis. So intervention should be considered in asymptomatic patients, and it's 2A indication. So intervention may be surgical or transcatheter. TAVI may be considered for treatment of severe bicuspid aortic valve stenosis in patient with increased surgical risk. If anatomy is suitable, we can do TAVI in bicuspid aortic valve. 2B indication is there. And surgical mitral valve repair in severe primary AR. So MR may be primary, or because of some pathology, or maybe secondary. So secondary to LV dysfunction or secondary to atrial enlargement. So they divide secondary MR into atrial secondary MR or ventricular secondary MR. And severe primary MR, regarding that, surgical repair is recommended in low risk asymptomatic patients with severe primary MR, and when durable result is likely. So it's a class 1 indication for surgical repair if results are good and center is good in experience. Then if at least 3 of the following criteria are there: AF or PA pressures more than 50, LA dilatation, or concomitant severe TR. So if the three of them is there, then in severe PMR we can do the repair. Minimal invasive surgery may be considered in experienced centers for this primary MR, and in secondary MR, mitral surgery along with surgical AF ablation if indicated, if AF is there, and LA appendage occlusion along, so that should be done in atrial secondary MR. If there is LA is dilated, AF is set in, then along with surgery they say that to the surgical AF ablation along with LA appendage occlusion. Then similarly, TR can be done trans esophageal. This we can do this TMBR by TR procedure with the severe atrial SMR, which are not eligible for surgery. So 2B indication is there for transcatheter procedure, and then mitral valve surgery may be considered in patient with moderate disease also, which are undergoing CABG. So if already patient is going CABG, then if it is moderate MR, secondary MR, then also it should be considered. 2B indication is there. Then regarding this transcatheter mitral valve implantation, so that in severe rheumatic and degenerative MS both, TMBI may be considered. 2B indication is there. And regarding intervention in TR, they say that we should first evaluate the etiology, carefully evaluate etiology, degree of TR severity, RB dysfunction, LB dysfunction, and PAH. And then we should decide as a heart team regarding the intervention on TR. And if there is a surgery of concomitant severe MR, then we can also consider tricuspid valve. Indication of intervention in patients with mixed moderate AS and moderate MR, moderate AR. So moderate disease is there. We can do the intervention, surgical or transcatheter, in symptomatic patients if mean gradient is more than 40, and asymptomatic patients also. If the EF is less than 50, then we can consider class 1 indication is there to intervene in a moderate AS, moderate AR combination. Prosthetic valve selection, so mechanical valve should be considered if the patient already having no contraindication for oral anticoagulation. 2A indication is there, and INR targets should be based on the type of and position of the mechanical valve and patient risk factor and comorbidity. So target should be fixed once you are doing surgery, and then we should educate the patient regarding that to improve the quality of oral anticoagulation. These class 1 indication, and onus comes to us as a physician that once post-op patient is there with you, we should not forget regarding the training of the patient, the self-monitoring of the some of the selected patient, they can do the self-monitoring of INR. That should be emphasized. So management of antithrombotic therapy, so we can continue the VKA treatment in patient with mechanical heart valve undergoing the elective non-cardiac surgery. So if there is a chance of no or minimal bleeding, then we can continue the anticoagulation and do the surgery. So that is there. Then interruption 3 to 4 days before surgery with resumption of VKA without bridging. These two new indications are there that we can do without bridge therapy. We can do in a new generation aortic mechanical heart valves. Without bridging, we can do the VKA, stop the VKA 3 to 4 days before and then restart it post-op. So that in new generation mechanical heart valves. Then antithrombotic therapy in biological heart valve. So lifelong low dose aspirin therapy may be considered 3 months after the surgical implantation of biological heart valves. And in TAVI, without indication of oral anticoagulation, DAPT is not recommended. So class 3, dual antiplatelet is not required. Surgical repair without indication of oral anticoagulation, so we can give the low dose aspirin in surgical mitral or tricuspid repair in preference to oral anticoagulation. 2B indication is there. Then we can continue OASE if the indication for oral anticoagulation is there, class 1, even in the surgical biological heart valve. If required, we can continue. DOAC also can be continued if indication is there. And oral anticoagulation and antiplatelet. So we can continue the oral anticoagulation and antiplatelet after surgical repair and patient with clear indication for these therapies. And reoperation is recommended in mechanical heart valve failure in symptomatic patients. And transesophageal echo and 4D CT, these are recommended for evaluation of valve thrombosis in suspected thrombus. CT angiography is recommended in patient with moderate or lower pre-test likelihood. In patients of CAD, in patient with valvular heart disease, we can do only CT CAG if the likelihood is less for CAD, and invasive angio is required when high or very high risk of CAD is there, pre-test likelihood, then invasive angiogram. So we can do only CTCA if less than 50% chance of CAD in pre-test. So invasive angiography is recommended in CAD in patient with severe ventricular SMR. Now we want to rule out the CAD. If the ventricular dilatation, LV dysfunction is responsible for this secondary MR, then do the invasive angiogram to rule out the coronary artery disease. Class 1 indication is there. And PCI may be considered if there is a more than 70% stenosis in main vessels. 2B indication is there. Surgical closure of LA appendage is recommended in patient with AF with native heart valve disease. So it can be act as a adjunct to oral anticoagulation. Surgical closure of LA appendage in AF patients. Concomitant surgical ablation can be done in patient undergoing mitral valve surgery if they are suitable for rhythm control. Class 1 indication is there for surgical ablation. And if the patient is undergoing non-mitral valve surgery with AF, if there is a suitable morphology, we can do 2A indication is there for surgical ablation. Then use of DOACs is not recommended in patient with native valvular heart disease in AF patients. If the mitral valve area is less than 2, then it is a mitral stenosis condition, then DOACs is not recommended for AF patients. And aortic valve repair should be considered in selected patient with severe AR. So now it is 2A indication for patients for aortic valve repair in severe AR. And evidence B is there, and they have added the one more criteria in aortic valve surgery for severe AR. LV and systolic volume index more than 45 ml per meter square. This was not there in previous guidelines. So now we can calculate this LV and systolic volume index before the aortic valve surgery for severe AR. And similarly, if the severe AS is there, then intervention is recommended for symptomatic patient with severe low flow, low gradient AS. So class 1 indication is there. And then normal LVEF patients more than 50%, also 2A indication is there in patients with symptomatic severe AS. So similarly, in patient with asymptomatic severe AS, if LVEF is more than 50%, then intervention should be considered in very severe AS, severe valve calcification or mildly elevated BNP, or LVEF less than 55 without another cause. Then we can consider in asymptomatic severe AS also to go for the intervention for aortic valve replacement, surgical or transcatheter.
आधा घंटा लगेगा.
It is in patients with symptomatic severe AS. So we should do the estimated life expectancy regarding decision for the whether we want to go for the surgical AVR or transcatheter AVR. So that can be decided by various factors: clinical, anatomical, procedural, and estimated life expectancy. So TAVI is recommended in aortic stenosis patients. Previously it was more than 75 years, now they reduced it to more than 70 years. So more patients can be included in TAVI for tricuspid aortic valve stenosis if anatomy is suitable. And SEVER is recommended in patient less than 70 years of age. So it is now less than 70, previously it was less than 75. So if the surgical risk is low, go for the SAVR, and if anatomy is suitable, then class 1 indication for TAVI is there. And SAVR or TAVI are recommended for recommended for all remaining candidate for an aortic bioprosthetic heart valve. Few slides more. Mitral valve surgery should be considered. They have added the LV and systolic index, diameter index, in the patients of severe primary AR. Otherwise, the same recommendations are there. In severe primary AR, the class of recommendation for transcatheter repair 2A is now there. It was 2B initially. So severe primary MR, we can do the TR in class 2 indication, and if severe ventricular secondary MR is there, we can do the PCI in followed by TR. 2B indication is there, and TR is also recommended if the patient is fulfilling specific clinical criteria and has severe ventricular secondary MR with concomitant coronary artery disease. So if they are not fulfilling also, then 2B indication is there for TR. So TR is now choice for class 1 indication for patient with to reduce the heart failure hospitalization in a severe secondary MR. Then if the patient is not suitable for TR, then 2B indication for there for mitral valve surgery in symptomatic patients. Concomitant tricuspid valve surgery is also recommended in severe primary or secondary TR, and repair should be considered. 2A indication is there, and mild secondary TR also 2B indication is there, and transcatheter now transcatheter tricuspid valve replacement can be done. So 2A indication is there now. Previously it was 2B, and for prosthetic valve selection, mechanical heart valve can be considered if there is a already indication for oral anticoagulation. 2B recommendation, and lifelong oral anticoagulation. Now evidence is A. Previously it was B for patients for mechanical heart valve, and INR self monitoring. So evidence is A now, and for management of antithrombotic and mechanical heart valves. So following cardiac surgery, now recommendation increase the 1 week class is there, and addition of low dose aspirin can be considered if failure of the oral anticoagulation in selected patients. So 2A recommendation is there. We can increase the target INR if the failure of the oral anticoagulation, or we can add the low dose aspirin and then try for the if the thromboembolic complication occurred. So increase the target INR or add low dose aspirin. We can we should not use DOAX or DAPT for this indication, and at least 4 days prior, if the patient is going for non-cardiac surgery, there is a lecture for this, and at least 4 days before major elective non-cardiac surgery, we should stop the VKA, and INR should be less than 1.5, and within 24 hours we should resume the VKA, or as soon as the hemostasis is achieved, we can resume the VKA. And VKA interruption and resumption with bridging should be considered in mechanical heart valve. Low dose aspirin is recommended for 12 months in patients with biological heart valve or valve repair, and after 12 months also we can continue with the ASA 2A indication is there, low dose aspirin, and in bioprosthetic heart valves. And oral anticoagulation is recommended for TAVI patients who have other indication for oral anticoagulation, and either VKA or DOAX should be considered during the first 3 months after surgical repair of mitral and tricuspid valve. Routine use of OAC after TAVI is not recommended, class 3. And heart team evaluation is required for paravalvular leaks and hemolysis, and transcatheter closure should be considered. 2A indication is there for these paravalvular leaks. Reintervention is recommended if the biological heart failure is there in symptomatic patients, if thrombosis is ruled out, and at intermediate or high surgical risk, suitable anatomical processes is there, then we can go for the transcatheter transfemoral valve-in-valve implantation for the failure of bioprosthesis. Intermediate or hard surgical patients also 2A indication for this valve-in-valve implantation. transcatheter. So heart team evaluation is required for mechanical heart valve thrombosis, and oral anticoagulation using VK is recommended if the bioprocesses is thrombosed. Before considering re-intervention, we can go with the VK therapy before. So key takeaways from the guidelines: early intervention is emphasized across aortic stenosis, mitral regurgitation and TR. Age cutoff for favoring TAVI lowered from the 75 to 70 year. More patient can be enrolled in a severe aortic stenosis, which is tricuspid. Surgery remains preferred for primary MR. Expanded guidance for secondary MR, atrial versus ventricular is there. Stronger recommendation for heart valve centers and lifetime management planning, and transcatheter tricuspid therapies gain a class 2 recommendation for symptomatic high risk patients. So now transcatheter tricuspid valve implantation is their option. Thank you very much.
Any questions from the house?
What is the status when there is a sinus formation of the aortic valve, setting aortic valve, with a significant hemodynamic gradient,
Whether it is
more than 30?
it is mechanical valve, then we have to do replacement or repair, because in this no other option is there. So surgically we have to go.
No, but if it is just the thrombus, then we usually
If
use
thrombus
the,
is there, we can thrombolyze
Yeah.
the patient,
Yeah.
or we can do the surgery. If
yeah,
that can be discussed with heart team, that is the says the guideline.
yeah.
But what is the natural history once there is a sinus formation and there is a gradually increasing the systolic gradient across the LV?
The patient is going in heart failure.
No,
And
not in heart failure, but patient is has developed the preoperative gradient to 2-3 times in postoperative after 6 months or 1 year, and there is a from echocardiography there is a sinus formation. So how will you guideline? What is the guideline says? What will you do? Will you wait for LV function to
Definitely.
go into dysfunction,
Definitely,
or you will have a some
definitely there should
some
be valve
criteria?
dysfunction, there should be stenosis or regurgitation, then only we can think of doing some surgical intervention, otherwise we can wait.
There was
Do you have any role of anticoagulation or any other way of
It's
controlling
definitely
controlling dyslipidemia in such cases? Do you have any idea?
very less role.
Any literature says something, a strict control of the lipid can prevent the sinus formation and slow the sinus formation of the aortic prosthetic aortic valve?
There may be some inflammatory thing, but there is no evidence like that. We can try like other inflammations we are
Dr.
getting.
Dr. Dharmendra, one of the slide you showed that indication for NOAC in the patient with mitral stenosis with AFib. So
They changed the cutoff. Previously it was for the severe or moderate, like that. Now they have given the less than 2, then should be no DOAC or NOAC. There should be VK. Less
Okay.
than 2. They have given clear cut. Previously, no, there is much confusion. Mild, moderate, severe. What is the cutoff? These are also changing. So they have come newer guidelines 2025. Less than 2, no DOAC, NOAC.
because we never use with the prosthetic valve this NOAC, because you know that none of these, like neither mitral or aortic, we don't use NOAC for post-op
It is not
anticoagulation.
prosthetic valve. It is severe mitral stenosis.
Yeah. So
Where we are talking about.
So
If after
philosophy
mechanical heart valve
philosophy is same, no?
only VK.
Philosophy is same, no?
This is a candidate for anticoagulation, not the NOVAC. So the degree of MS is important to consider NOVAC or oral anticoagulant.
So more than 2, you will give
NOACs.
NOAC, otherwise vitamin K antagonist.
It's clear cut now.
And was
Cutoff is there.
there anywhere in the guideline that TAVI, indication of TAVI in low risk patient with the aortic stenosis in younger patients? Does it have any indication at all?
It's not in the guideline, but they are doing nowadays. On the patient's choice, studies are there.
Okay. Irrespective of
Patients are getting benefited.
Yeah, okay. All right.
But it's patient's choice first.
Thank you, Professor Jain, for nice deliberation. Now I request Dr. Krishna Ji Pandey to give memento to Professor Dharmendra Jain sir. Now I request Dr. M.K. Srivastava sir to give memento to Dr. Krishna Ji Pandey. I request Dr. V.B. Singh sir to give memento to Dr. V.P. Singh sir. Once again, I request Dr. V.B. Singh sir to give memento to Dr. Sudhakar Singh. So now the last session of the today conference, session 6. For chairing this session, now inviting Dr. B.K. Singh sir. Sir, please come on the dais. Dr. Aswani Tandon sir. Sir, please come on the dais. Dr. R.N. Vajpayee sir. And Dr. M.K. Srivastava sir.
बैटिंग वही करेंगे वाराणसी सबसे पहला प्रश्न कर बॉस हाँ बुलाई बॉस आई बॉस
So, good evening. This is the